Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case about a 34-year-old male who came to our ER with complaints of rashes all over the body with abdominal pain and joint pain since the past 4 days.
When rash come to emergency room, what all precautions you have to take?
So the rash can be like infective and
Most of the rashes in our country is infective. You have to be very careful.
yeah. So we have to be wear personal protective equipments, and the patient should be isolated and should not be in contact with other patients.
If you don't have isolation facility in emergency room, what do you do? What is the distance of spreading of bacteria, virus through respiratory tract? Distance.
5 meter, 5 to 10 meters.
Maximum distance can be spread through cough, sneezing and all. It is only 1 meter. But what we are worried is when it comes down to the floor, if you don't do the wet mopping, then it can spread everywhere. So that is a problem. But in our hospital, it is like a normal protocol. It is wet mopping only. But at least 1 meter distance you have to try to keep away from the patient, or you have to wear the personal protective equipments, but other patients are the concern. The nearest patient should be kept away. So that we have to take care. Okay.
So this patient was 34-year-old male, and on initial 10-second assessment, the patient was conscious and oriented and was obeying to commands. Coming to the primary survey, the airway was patent and there was no pooling of secretions. In breathing, air entry was bilaterally equal and respiratory rate of 18 per minute with saturation of 99% maintained in room air. And coming to the circulation,
if patient who is having rashes is in altered behavior, what are the differential?
meningoencephalitis.
Which meningoencephalitis?
Yeah.
What is that? What?
Meningococcemia.
Meningococcemia. Then what else? What are the conditions where you have rashes with altered
Measles.
measles? Children, it is not very common, but you can get later stages of measles. Encephalopathy is there. Then you can get any viral infection with rash can have some encephalopathy. Initial phase there can be toxic encephalopathy. Later it can be real encephalopathy. But specific condition where the rashes are there, patient is having altered behavior. Like you told, meningococcemia is one of the important condition where we have to take a lot of precautions. Then in our country, one of the important condition is typhoid. Typhoid in the third phase or late second phase, patient can have encephalopathy. Okay. Meningococcemia, what are the clinical findings which may tell you clinically this is meningococcemia?
Neck rigidity, neck pain.
Neck stiffness, okay. Neck rigidity, neck stiffness.
Then headache with altered sensorium.
Okay, then rashes. Then what is the most striking feature of meningococcemia?
Decrease urinary.
What happened to the BP? That is very important. What is that syndrome called as?
Waterhouse filtration.
What is that? If you come across any case who is having rashes, hypotension, shock, how do you manage?
IV fluids.
No. IV fluids are there, definitely that is there. But what is the mechanism? What is Waterhouse-Friderichsen syndrome? You have told it.
Toxin related.
No. Where is the hemorrhage? Which gland is? Adrenal failure. It's an adrenal hemorrhage and adrenal failure. What is the treatment? Steroids. Okay. So you have to know all these things. Any patient who is having rash, hypotension, shock, neck stiffness, first differential diagnosis in our country is meningococcemia. Give steroids immediately. Okay. Anyway, this patient does not have all these things.
And in circulation, heart rate was 80 with BP of 120 or 80, and all peripheral pulses were palpable. Coming to the disability, GCS was full score with the pupil bilaterally equally reactive, and the pain score was 6 out of 10.
Why pain? Where is the
Abdominal
pain?
pain and joint pain was there. He was having severe abdominal pain initially. So initially we gave him a paracetamol.
So what are the condition where you get abdominal pain with rashes?
One is like acute porphyria.
That is the commonest thing. How many porphyrias you have seen so far? How many porphyrias you have seen so far in your MBBS life?
Typhoid.
Typhoid. Commonest is the typhoid. You should think common condition. Abdominal pain, rashes, fever, typhoid is first condition. Then dengue fever is very common in our state. So that is the second important condition. So these are the common condition where you get abdominal pain, rashes, fever, all these things.
Then
Continue.
in exposure wise, temperature was febrile and patient was exposed, which was showing purpuric rashes all over his body.
Okay.
And coming to the adjuncts, actually,
So when you get a rash like that along with fever, what else you will ask?
history.
History of
History.
So first fever, then development of rash.
Of rash.
Okay, one is the day of development of rash, by which you can make out some type of viral exanthematous fevers. If rashes occurring only during fever episode, then what is that? Only during fever episode, patient is developing rashes. Once you give paracetamol, rashes disappears. Or once the temperature subsides, rashes disappears. What is your diagnosis?
Viral.
Viral, it will not disappear like that. What is that? That is adult onset Still's disease. Okay, that is one of the important differential diagnosis for rashes with high degree temperature in emergency room. It looks like a viral exanthematous fever. Once you give paracetamol, immediately fever subsides. The rashes also will subside. They also present with sore throat. So you may think that it is a viral fever. What is a lab investigation which will tell you that this is adult onset Still's disease comparing with normal viral fever? What is that? It is ferritin. High levels of ferritin indicates a condition like adult onset Still's disease. Okay. Even some viral fevers you are seeing dengue fever and all, high ferritin is coming nowadays. Macrophage activation syndrome. They are going to macrophage activation syndrome. Okay.
So in adjuncts, VBG was taken, which was normal. No ask-based derangement was noted. And coming to the secondary survey, the patient was a 34-year-old male who came with complaints of initially rashes. It was started rashes all over the body, and it was like 4 days back, followed by abdominal pain and joint pain. But there was no history of any fever, vomiting, or altered sensorium. No history of any constipation, loose stools, throat pain, and no history of any trauma.
Okay.
And patient initially went to nearby hospital and was managed with normal analgesics, but as his symptoms were not subsiding, patient came to a hospital for further management.
Patient with fever with rash, before giving analgesics, what you want to rule out? Giving analgesics. Fever rash is very common. It can be due to normal viral fever, dengue fever, leptospirosis, typhoid fever. Before giving analgesics, that is NSAIDs, what you have to rule out? Allergy anyway you will rule out, no? But we give tablets, diclofenac or coxibs. What you have to rule out before that? One is elevated creatinine. Second thing is platelets. Low platelets, try to avoid NSAIDs. Why? What is the action of NSAID?
COX inhibitor.
Aggregation.
Reduces the aggregation. It increases the bleeding in a patient who is having already low platelet count. So you have to be very careful. Okay. So try to avoid. It is not that we should always go in that line. If the platelets are okay, then you can give. Rashes are maybe due to some other reason. Okay. So before that, rule out renal failure and low platelets.
On reassessment, his pain has reduced to 3 out of 10. And upon evaluation, systemic evaluation, GIT was soft and non-tender. But as he has having abdominal pain, severe abdominal pain initial evaluation, we had also asked for one X-ray abdomen and USG abdomen also.
X-ray, what X-ray abdomen you want to take?
X-ray abdomen erect.
Erect. Why you want to take?
To rule out any bowel constipation.
Gas under
Gas under. That
diaphragm.
is the answer. We are taking an X-ray abdomen only to see whether gas under diaphragm is there or not. And the fluid levels also definitely in any case you can make out by X-ray, but that ultrasound will be a better tool to diagnose it. But gas under diaphragm is very important. Where you get gas under diaphragm?
Perforation.
Perforation. Okay.
And also we are sent for routine investigations, and in which CRP was 104 with the total count of 11,000 and platelet count was 3,07,000. Other than that, urea came out to be 33 with creatinine of 0.7. PT INR was also sent. INR was 0.9 with APTT of 26.
Okay.
All other lab results were within normal.
What is your diagnosis?
So, as the patient came with complaints of palpable rashes with abdominal pain and joint pain, can be HSP.
What is a typical feature of HSP?
HSP patient will have palpable purpura with two of the following three features, which include abdominal pain, joint pain, and kidney involvement.
Where is a rashes normally? Where all you can get rashes? Classical rashes in HSP occurs in which part of the body? Lower limb. It is mainly in the lower limb. Sometimes you can get in the trunk also. Otherwise, it is mainly in the lower limb. How do you classify purpuras? Purpuras are due to various reasons, no? What are the common reasons for purpuras?
Because of bleeding.
Okay, it can be due to bleeding. It can be due to blood vessel problem. Okay, how do you differentiate a bleeding? That is, coagulation defects will not produce purpura. That produces larger bleeds, ecchymosis. Platelet defects can produce purpura. Vasculitis can produce purpura. How do you differentiate these two?
Skin biopsy.
Do you need to send to dermatology? It takes one day, no? Clinic in your emergency room, how do you diagnose it? Is it a palpable purpura or no? That is the answer.
Blanching.
Palpable purpuras are classical features seen in vasculitic purpuras. Whereas your platelet disorder, sunlight purpura, so many other things are non-palpable purpuras. Okay. So here it is palpable or non-palpable? It is a palpable purpura. Okay. So here you have two differential diagnoses. Is it viral fever or non-infectious? So how do you then proceed?
Here there was no fever actually.
Okay. There is no fever, but rashes are there. So mostly it is vasculitic purpura. Vasculitis purpura again divided into like HSP and other immune-mediated disorders like SLE, various other disorders, and like what is it, macrophage? ITP is a platelet purpura, no? It's not a palpable. Macrophage activation syndrome, there also you can get purpuras. Now what do you do?
So we have to...
What is the most important problem in emergency room because of this HSP? HSP is a benign condition. We no need to worry about that. What is the problem in that type of patient? What all complications can occur in HSP? So
HSP patient will have the above features, and the abdominal pain. The patient might have bowel wall edema with bowel wall ischemia and may lead to perforation. So
most important diagnosis you have to make whether the patient is having a ischemic bowel disease or not. You have to ask about the history of blood in the stools. That is very important. If blood in the stools are there, then you have to be very careful. Other important organ involved in HSP is kidney. So you have to ask for a creatinine level. Urine protein also can be sometimes elevated. If nothing is there, it's a benign condition. Then how do you manage it?
Can give painkillers, NSAIDs for pain, and also steroids if needed.
Okay. What happened to this patient?
This patient we have also sent for other results like skin biopsy was sent and also C3, C4 was sent.
What routinely skin biopsy will tell what type of vasculitis it is?
IgM mediated vasculitis.
Leukocytoclastic vasculitis. That will be the report you will be getting.
Yes.
Okay. So if that is the report, then no need to worry about the case at all. Okay. Then you told about C3 and C4. What is that?
Complement mediated.
What is that? Why we want to send it?
C3 positive, C3. Differentiating the vascular.
Unnecessarily don't send any investigation. That is the most important. Sending all the investigation without knowing, that is not correct. You should know why you are sending. There is a reason for that. in an immune-mediated complex, complements are utilized. So in acute inflammation, a complement-mediated inflammation, what happened to C3 and C4?
It will reduce.
It will reduce. We are sending to see whether any complement-mediated injury is there or not. If the complements are utilized in large quantity, the levels will be very low. That's why we are sending C3, C4. And this HSP as such, we no need to send. There is a renal involvement, then you have to send, because that is an important problem because of this complement mediated injury. Otherwise, it is not required at all. What happened then?
The patient pain got reduced, and now we are awaiting for the skin biopsy reports. Patient is stable, and
Should we admit this patient in an emergency room? Ideally, admitted or not? Should we admit or not?
we had to rule out bowel wall ischemia.
That is the only thing we have to be careful. Abdominal pain is there, so bowel wall ischemia we have to rule out. Then you can discharge the patient. He does not require any treatment also. You can advise the patient this is a normal phenomena or altered immune response. He will not have any problem because of that. If at all he develops some elevated creatinine or something like that, he can start on steroids, mycophenolate, mofetil, azathioprine, like that. You can. Otherwise, nothing is required for this patient. Then another important differential diagnosis, we have told already. What is that? Adult onset Still's disease. What is the presentation of that disease? It will be resembling like a viral fever. Sore throat will be there, high degree fever will be there, rash will be there, joint pain will be there. So they are all features of viral fever. Only thing is the rashes will come during the fever episode, disappear after the fever episode. That's all. Their ferritin levels are very, very high, 10,000, 20,000, that range. Okay, that you have to, suppose you are not seeing that this is not HSP, then you have to think about Still's disease. So that sometimes it can be dangerous because it's a part of many malignancies or other rheumatic disorders. It can be dangerous sometimes. So normally that also subsides with minimum treatment. This patient is discharged.
Waiting for the biopsy result after discharge.
So this is a case of this is a case of enoxaparin purpura or vasculitic purpura. Does not require any major treatment. Only reassurance is enough. If at all you want that cosmetic change, you can give some steroid ointment, steroid tablets. But steroid tablets will have its own side effects, adverse effects. So we don't continuously give on steroids. Can steroid produce purpura? Steroids also can produce purpura. After some time, the skin will become thin, the blood vessels will become thin. It can produce purpura. So steroids are also not a good treatment option for this. Whenever patient is having large number of eruptions, you can use steroids. Other drugs like azathioprine, mycophenolate, mofetil, they all got their own side effects. So we don't routinely give. Only if the patient demands, cosmetic changes can occur, then only you should give. Okay, thank you.